Mr. McManus is a gentleman who's actually in extremely good health until very recently. What led him to be brought to to medical attention was the fact that he started coughing up blood. This led to fairly routine x-rays that showed that right at the point where the trachea bifurcates into the right main stem and left main stem bronchus in the two lungs, he had a a polypoid growth coming off towards the right-hand side. He'd also had a bronchoscopy done. They saw this polyp, they biopsied it, and they called it a type of sarcoma, a leiomyosarcoma. That itself would be an unbelievably rare tumor to have inside the airway. Then he came to see me to just talk about what the options were.
I was very much relieved that once I reached out and had my slides and materials sent up here, that there was a sarcoma specialist that was willing to see me rather quickly.
In 5 to 10% of the cases, we actually disagree with the outside diagnosis. In our opinion, the material was not diagnostic for a leiomyosarcoma. I thought that this most likely fits with a different type of tumor, which is also smooth muscle indifferentiation. It's a Glomus tumor. We contacted Dr. Downey right away that we disagree with outside diagnosis, and second, maybe additional material, additional biopsy can help in establishing a more firm diagnosis that this is a Glomus tumor, and therefore a more marginal resection should be done.
We presented this case of what we call our thoracic tumor board. The consensus was these are very low-grade tumors, so basically we just had to do a local excision only. The difficulty was that it was at the end of the trachea, right at the branch point on the right-hand side. The right main stem, which is where this tumor is located, is actually extremely short. It wasn't at all clear that you could back away to a normal piece of tissue to ensure negative margins. You'd be worried that you're cutting just simply through the tumor, and it's inevitably going to grow back. We mapped it out just with bronchoscopy and thought we had enough room. The technical challenge was that the airway narrows as it gets further and further distal, presenting with a size discrepancy between the proximal and the distal ends. So what you tend to do is cut across the larger ones straight across, and the lower one at an angle, and the bevel increases the size of the opening that you have to sew things together. We were able to cut across just above the tumor and at an angle just below, and then bring the entire rest of the airway going to the right lung and sew it back together again. It was almost like a lung transplant without having to do anything to any of the blood vessels. I believe he was in the hospital 3 days. As soon as the chest tube came out, he was able to go home.
He really appreciated the fact that I was a runner and knew how much I appreciated my lungs and wanted to keep them intact. He jokingly said if they did remove an upper lobe of my lung, at the worst I'd lose 10 minutes off my marathon time.
Since we don't know very much about this tumor, we treat him as we would any lung cancer patient. And so he's being seen every 6 months with a CAT scan.
You know, by the time I got to the Boston Marathon, I just was so grateful.
I actually didn't recognize who had sent me the card, but out of the blue a card showed up showing somebody crossing the finish line and a thank you on the back. I believe it was actually 6 months after he had had the operation, which is kind of cool. I think he would have been able to run the marathon even with one lung, but having two lungs, I'm sure, made it a little bit easier.